recorded for sharing later. Thanks everyone for being here. We are really happy to have Dr. Michael Knight with us again. He presented this presentation at our conference and was very well received, so we wanted to make it available to a wider audience and also have the opportunity to record it. So if you have some questions, you can go ahead and put those in the chat, or we can take some time at the end to address those as well. But Dr. Knight, thank you for being here, and I'm going to go ahead and just let you get right to it.
All right, well, thank you, and hello, everyone, and hope everyone is doing well this afternoon. For our folks and friends down in Tennessee, I was excited to be with you all for the TCCN annual conference in Nashville, where we talked about COVID-19 and vaccinations. Where are we now? I was hoping that this would just be a repeat performance, but with the changes that we've seen in the last week, I have made some updates. So if you've heard it before, you will receive those updates again. Again, I'm Michael Knight. I'm an internal medicine and obesity medicine physician, as well as a healthcare educator and a healthcare leader in quality population health and community primary care. I'm currently the head of services at Impact Care, which is an organization that supports healthcare entities across the United States in building and expanding community health worker programs to improve population health. So let's think about where we were in March 20 of 2020. I mean, this was a time where we had heard about a virus called COVID-19. It had come into our communities across the United States. And at this point is where a large of us were impacted by shutdowns, by increased volume of patients and community members who were coming into our hospitals and clinics with an infection for a virus that we had never heard about. It was a scary, scary time. And what we knew at that point was we didn't have any vaccines. We didn't have any effective treatments, and thousands of people were being negatively affected. I think if we all think about our own communities, our own families, our own homes, all of us know at least one person that was affected by COVID-19. And unfortunately, we've lost so many to this virus. Now, the benefit is that we're not at the peak as we were at that time. We have tools that are effective in helping to treat and prevent COVID-19, but it's oftentimes that we need to not forget the experience and what we saw. You know, when we think about the history of the United States, that COVID-19 is not the first pandemic we've dealt with. Back in the early 1900s with the flu epidemic, we also had a similar situation where particularly communities that were under-resourced or who had been underserved bore the brunt of that pandemic. And so as we think into the future, where we may see another pandemic, what have we learned and what can we learn from what we've gone through with COVID-19? So when we look back again, we can't forget that we've had in the United States until June of this year, when we really stopped collecting confirmed case data, over 100 million people who had been infected with COVID-19 and over 1.1 million deaths. And I think we just have to pause when we think about that number. 1.1 million of our colleagues in the United States and many more around the world who lost their life to this infection. So where are we today? It's September 19, 2023. I'm sure almost everyone who is listening to this or who is on live has heard not just one, not just two, but probably about 10 COVID-19 presentations. So why are we still talking about it now? And where are we now? Well, many of you know that if you've seen the news recently, you have seen the headlines around a new COVID wave hitting this summer, or a summer surge, or variants that have been identified. And we're going to talk about all of those things today. But that leading to a rising in COVID hospitalization or ED visits is what continues to keep COVID-19 at the top of our headlines. Let's think about the statistics that we're seeing thus far in September of 2023. We know that back when I made this presentation initially, we were starting to see a peak or a surge, if you will, of not only cases, but hospitalizations and ED visits. What we identified is that because most people are testing at home and may not be testing in the doctor's office, we don't have accurate counts of how many people are infected with COVID-19. But what we are able to track is how many people end up in the emergency room or are admitted to the hospital with a COVID-19 related diagnosis. So we understand that that undercounts or vastly undercounts the number of infections, but it can give us a indication of any changes that are happening in the community. So by mid-August, we were seeing about 15,000 new COVID-19 hospital admissions across the United States, which represented a 19% increase from the previous week for COVID-19 hospital admissions. And specific to Tennessee, we had seen at that time about 300 new COVID-19 hospital admissions in that week, which was a 33% increase. So again, we had come down so very low in May and June, and then by July and August, started to see an uptick. Not just an uptick in infections, but an uptick in the effect it was having on individuals because this led to hospital admission as well as ED visits. Where are we now? Just in a couple of weeks, that number has gone up, though it is leveling out. So with now over 2,000 new COVID-19 hospital admissions per week in the United States, but the increase from the previous week has gone from about 30% to about 7.7%, meaning that we're increasing, but more slowly. And the trajectory continues to go. In Tennessee, we're now over 450 new COVID-19 hospital admissions per week, which is a 12.3% increase from the previous week. And we can then see that compared to the national increase from the previous week, we are seeing a bit more in Tennessee. When we think about emergency room visits, this also is a great opportunity to reflect. Where in the past week, about 2.3% of all ED visits in the United States by the end of August were related to COVID-19. Indicating an almost 20% increase. And in Tennessee, 3.1% of those ED visits were related to COVID-19, which represented a 32% increase. Where we see where are we now, those percentage increases have gone in the opposite direction, which is a good thing. And so even though the ED visit percentage rate is about the same, we seem to have peaked when it comes to that. And when we think about those different data points, so number of people infected, ED visits, hospital admissions, it usually follows in that pathway. So we usually see first the number of people infected go up, then the number of ED visits, the number of hospital admissions. And then when we start seeing infections coming down, ED visits go down, and then hospital admissions go down. So we already seem to be on a downward slope with what we're seeing now with regard to ED visits, and we expect that that will affect hospitalization rates in the near future. However, we also know that going into the winter season, we anticipate another potential surge in COVID-19 infections. Where are we doing with regard to vaccination? This was a huge part of the work that TCCN member organizations did, which was education around COVID-19 vaccines. The reality is that the majority of Americans have been affected by COVID-19 in some way. And so our goal was not just to limit infection, but to say if you are infected, we know that with vaccination, your risk for a poor health outcome is much more reduced. And so those efforts have led to a great uptake in taking at least one vaccine, which 88% of adults across the United States have had at least one dose of a COVID-19 vaccination. We also, if we look to the part of the slide where we identify race and ethnicity, you'll see here that a lot of work was done to close the racial and ethnic gaps in vaccination by addressing vaccine hesitancy and addressing the concerns that were present in many communities to a point now where across the board, we see similar rates of vaccination in various racial and ethnic communities. When we think about our status in Tennessee, overall, about 84% of Tennesseans have received at least one dose of the COVID-19 vaccine. And once again, we've also seen here that our racial and ethnic group data has improved and almost aligned. And so that is also a benefit of the work that many of you have been doing in your own communities. But where are we with regard to booster status? And what we will realize is that we're actually moving away from the term booster because the expectation is that every year we likely will see a new COVID-19 vaccine formulation come into market, which we'll talk about very briefly. But before this year, we would refer to the new dose as the booster. And the most recent was the bivalent booster, which the CDC recommended that all adults or all individuals greater than the age of 6 months receive. But only 17% of the total population in the United States actually got the bivalent booster vaccine. When we think about booster vaccination rates in Tennessee, only about 11% of the population had received it or is up to date as the CDC had noted it at that time. We see here that the highest uptake for vaccine boosters was in those age 65 and older. And we see here a drop off as you go down on the age. You also see the spread here across counties geographically, where we see some of our more urban centers with higher rates of booster vaccination, with some of the highest rates in Nashville and Knoxville, and some of our lowest rates, which is the darker color, in some of our more rural communities in Tennessee. So what are the COVID-19 vaccination guidelines? And I've actually had to update this just since my presentation a couple of weeks ago in Nashville, because now the vaccination that are being recommended are the Moderna and Pfizer 2023 to 2024 formulation, with this a monovalent vaccine. So bivalent and monovalent only tells us, are we targeting two different strains or are we targeting one? And with this one, it has been formulated to align with the most common strain that was seen in May and June of this year when these vaccines were developed. So the current recommendation is that COVID-19 vaccination is recommended for everyone aged 6 months and older in the United States, with an updated formulation of a COVID-19 mRNA vaccine, which would be Moderna or Pfizer. For those who are not moderately or severely immunocompromised, so for people who are at average risk, for children, you can see here the recommendations of at least 2 or 3 updated vaccines for those who have not been vaccinated, and then 1 or 2 of the updated vaccines if they have received a previous dose. And everyone else that's age 5 and older should get one updated Pfizer or Moderna vaccine. So when I say updated, I'm referencing the 2023 to 2024 version that was just approved within the last 2 weeks. A big update for everyone is that the bivalent mRNA COVID vaccine are no longer recommended in the United States, because now we have a version that is much more up to date and does target some of the variants that are mostly circulating in the United States. Whereas the bivalent booster, while it was effective last year in addressing the variants that were circulating, is not as effective now. And so this is something that we often will get this question from patients and community members that says, I already got the bivalent booster. Why should I get this new formulation that's out there? Hopefully the information you receive in today's talk will enable you to have those conversations. Another big update is that currently additional doses of the updated mRNA vaccines are not currently recommended for people aged 65 and older who are not immunocompromised. The previous bivalent booster was one where if you were 65 and older, you can be eligible for up to 2. Based on the current evidence, that is not recommended for the updated vaccine. So just as a real quick, because I went through this very quickly, everyone 5 years and older should get one updated Pfizer, BioNTech, or Moderna COVID-19 vaccine. Bivalent boosters are no longer recommended in the United States, and additional doses are no longer recommended for individuals that are 65 and older. The Novavax COVID-19 vaccine remains available, particularly being recommended in limited situations for those who completed primary vaccination using any FDA-approved or authorized vaccine and have not received any previous booster doses and are unable or unwilling to receive an mRNA vaccine. So for a patient that does not have a contraindication and that is open to Moderna or Pfizer, they really should not be getting the Novavax vaccine. And that really should be restricted to folks who are completely refusing or may have a contraindication because of an allergy or other reason to the updated vaccines. For people who are immunocompromised, for people aged 6 months and older, for the initial vaccination, they should receive 3 of the updated mRNA doses in a schedule. And those who have gotten a previous mRNA dose, if someone is 6 months and older that is immunocompromised, they should receive 1 or more updated mRNA vaccine doses. So let's talk about variants. So when we think about why are we getting another vaccine formulation, I've just convinced my patients to get the bivalent, and now I have to explain to them that the bivalent booster is no longer recommended, and now there's a brand new one, right? You can think about all of the theories that will come into someone's mind. Is it a scheme? Is it a money-making situation? Am I being a guinea pig? Are you experimenting on me? The way that we explain this is by understanding the physiology of viruses. When a virus enters the body, it invades our cells and it replicates. So when it makes copy of itself, it's not an exact copy. So think about leaves on a tree. They may all look very similar from afar, but if you hold the both 2 leaves up to the light, you'll see that the spines are different, right? And that's very similar with viruses. So when they make copies of themselves, it's not a 100% duplicate. There are small changes that are made during the copy process, and we call these mutations. A virus that has mutated is then referred to as a variant. So when a new variant has different properties that change the way that it behaves, or makes it become established in a population, then we may call it a new strain of the virus. So just to recap, when viruses replicate, they have little changes called mutations. And when there enough of those mutations happen that cause that virus to maybe change in their behavior, it becomes a variant and then another strain. So we have to understand that all viruses mutate, right? But most of the time, variants don't impact how a virus works. So it may, if you think about someone who is changing their clothes, right? I may put a different shirt on, but it's still a shirt and doesn't change who I am. But if I put on armor or if I put on a sports uniform, that may change how I'm going to work. And it's a similar way with these viruses. So when there are mutations that change the way it works or its ability to cause infection or disease, that can provide it a selective advantage over other viruses. So that increases the likelihood that it will go on and infect another person. So some of those characteristics include making a virus spread more easily, affecting how well someone responds to a treatment for the virus, impacting testing for the virus and how well it's picked up, reducing the effect of vaccines against the virus, and then causing more severe illness from the virus. So again, just imagine if you have a virus that is being covered by, we've gotten this booster vaccine, our bodies are fighting the virus, so virus infects us, we clear the infection very quickly, eventually that virus will stop circulating in the community. But what happens is when the virus keeps replicating, it's changing. And if that change affects its ability to be neutralized by our antibodies or be basically prevented by a vaccine, then that virus now is going to take off because now it can evade immunity. And that becomes the next variant. Or maybe it changes in the way that it's transmitted, so it makes it more easily transmitted. That virus will then take off, or that strain or variant will take off. So with SARS-CoV-2, which is the virus that causes COVID-19, we know it's constantly changing. It's been moving through millions of our bodies for the last 3 years. So every time we think about it, it's changing. And the genetic code mutations that are happening are allowing for that to happen. We expect that new variants will continue to come of COVID-19 as long as it continues to circulate in our community. So what we know is that when we see that consistent mutation over the course of the pandemic, that has had to require us to change our approach to vaccine and vaccine development. So once again, when our patients or community members say, I don't understand why I got my vaccine back in 2021, 2022, why do I need to get another vaccine now? Are you saying that you were lying to me? Are you saying that the vaccine that I got back then really wasn't real? Like, no, actually, it was very effective for the virus and how it looked at that time. But the virus of 2021 is not the virus of 2023. And so once we explain that and explain how viruses change over time, then people can better understand that it's not that the booster you took didn't work, it's that it was designed to address the virus as it was at that time. And as long as it continues to circulate in the community and continue to change, we're going to have to continue to change our approaches to make sure we can effectively prevent infection and reduce severity of infection. When we look at the spread currently, and this is the most recent data that came out on the 16th of September, where are we with regard to variants? The largest variant that we have seen now is one that's called EG.5. So there's a lot of different names that are circulating, but the most common variant right now is what we see at the top here, which is EG.5. Back in June, end of May, the most common variant was that XBB.1.5, and that is the strain that our current vaccine was made to target. So you may say, okay, doctor, now you just said that the variant that was circulating back in May is what these newest vaccines have been developed to target, but now it's not the main variant. So why would I take the vaccine? What we know is that there is a family tree, right? And so if we look back here, this is the variant that was most prominent in May or June, and the one we're dealing with now is a cousin, if you will. And so the way that the vaccine was developed, we see cross-reactivity or an effectiveness in similar variants. All right. So again, just think about it as like a cousin of the variant back in May or June that is now circulating. And lucky for us, the vaccine is still effective at a certain level to the variant of today. So once again, the current dominant variant is EG.5, also referred to as ERIS. It is a descendant of Omicron, which we were dealing with last year, just like XBB.1.5 was. So about a 20% of new COVID-19 cases are now thought to be related to EG.5, which is a significant jump from just 7% at the first week of July. We believe, based on the data, that this variant has a selective advantage in that it has a mutation in its spike protein, which is the part of the virus that helps it get into the cell, that allows it to evade some of the immunity that has been acquired from previous infection or vaccination. So again, thinking about how vaccines work, that bivalent vaccine that we got last year enabled our body to make antibodies against COVID-19. So COVID-19 virus comes into our bodies, the antibodies are there to attack it and remove it or neutralize it, if you will. But with this new variant, it has a mutation that allows it to evade those antibodies, and the antibodies can attach to them and neutralize it. So what does that mean? That means the immunity that I have from a previous infection, from a booster last year, may not be effective in neutralizing EG.5. And that is why we saw such a spike over the last 2 months in infections. I think most everybody on this call has heard about someone who's had COVID-19 in the last 3 to 4 weeks. So this is something that we're seeing. So there's also some early reports that it may be more transmissible than previous subvariants. So this combination gives the strain an edge over other recent or former variants. So what are the symptoms of this new variant? They're very similar to other Omicron strains. Tends to infect the upper respiratory tract, so that's going to give you the runny nose, the cough, versus the lower respiratory tract, which is where we see COVID-19 pneumonia. However, people that are 65 or older or who have a weak immune system are at higher risk for having that virus travel to the lower respiratory tract and actually cause severe illness. So what are some of the symptoms from EG.5? So they include the symptoms that we are very familiar with at this point, which include fever, body chill, fatigue, chronic cough, headache, sore throat. There's no way to say, oh, if you have this symptom, you know it's EG.5. The symptoms are very similar. And so when we think about upper respiratory infection or upper respiratory symptoms, we need to be considering, could this be a COVID-19 infection? So vaccination and the COVID-19 variants, again, the current vaccines are designed to give a broad protection against COVID-19. And as new variants arise, new approaches in vaccine development may include changing the dose, having additional booster vaccination, combination vaccinations, or adapting the vaccine themselves to target specific mutations on the variant. So while there's not a specific vaccine for the current dominant strain, which is EG.5, data suggests that this updated COVID-19 booster that was just released or just approved last week that targets the cousin XBB.1.5, the former dominant strain, will offer some level of protection against EG.5 because the two subvariants are similar in structure. So in August, there was some preliminary data that the Moderna vaccine did have cross effectiveness to EG.5 and the FL1.51, which is another variant that is picking up in the United States. And so the updated shots from Moderna and Pfizer that are now authorized by the FDA and have been recommended for all people aged 6 months and older by the CDC. So what can you do to protect yourself from COVID-19 variants? It's the same COVID-19 prevention tactics that we all mastered back in 2020. They're still in effect today. So being vigilant about hand washing. Consider masking when in a crowded place or when you yourself are having symptoms. Again, I don't think that we're going to go back to a nationwide mask mandate, but it's just something to keep in mind. And if we see someone who's wearing a mask, don't make a big deal of it. Maybe they're not feeling well themselves. Testing yourself when COVID-19, for COVID-19, if you're experiencing symptoms. So far, we have not seen variants that have evaded our current testing methodology. So our tests are still effective. However, it's important to look and to keep in mind that all COVID-19 tests are not going to be authorized forever. So if you're using an outdated test that's expired or something that's been around for a couple of years, you always want to make sure that there's not a new variant that's moving around that's not going to be picked up by that test. But luckily, so far, the tests are picking up our current variants. It's also smart to keep up with the lifestyle habits that we know support immune system and overall health. So those are things like a well-balanced diet, getting regular exercise, staying properly hydrated, and prioritizing sleep. How do we stop variants? The way that you stop variants is by stopping replication of the virus. As long as the virus continues to circulate widely in the population, it will continue to replicate more, and the likelihood that variants will appear will increase. It's just science, folks. So as long as the COVID-19 keeps circulating, it will continue to mutate. We'll continue to see variants. So when our patients ask us about it, this is why. So that's why we are working together to reduce the spread of COVID-19, because ultimately that is the only thing that will stop the development of future variants. It's the most effective way to do that. One other thing that we think about is how does the health department or the CDC track variants? It's tracked by looking at testing data, but it's also tracked in wastewater. We do know that individuals who are infected with COVID-19, sometimes if you don't even know it, will excrete the virus, and that goes into wastewater and is able to be picked up in surveillance. So that concludes our presentation for today. I'm happy to take some questions. This is my contact information. I hope this was helpful. I'm sure many of you will be dealing with community members and patients who have many questions. So I hope this was helpful in presenting an update on where we are now. Thank you so much. I'll turn it back over to you, Maddie, if we have time for some questions, I believe.
Yeah, thank you, Dr. Knight. Any questions? Feel free to take yourself off of mute or put it in the chat.
While folks are thinking of questions, one more thing I wanted to highlight. One question you'll get is, I just had my booster a couple months ago. Should I get the new booster now or should I wait? So the recommendation is that the booster is given about 8 weeks, so about 2 months since the last booster. So if someone just got their booster at the end of August or beginning of September before the new version is out, the official recommendation is to wait about 2 months before they get this additional dose.
Great to know. Let's see. Might have a question in the chat here. Oh, comment from Christy. Thank you so much. Well, I'm guessing we might not have a whole lot of questions because your presentation. Oh, here we go. Hang on just a second. I spoke too soon. How long should someone wait after an infection?
This is a great question. So technically, early on in the pandemic, the CDC had originally said, if you have a COVID-19 infection, it's okay to wait, 4 months or so before you get a vaccine. The idea at that point was that vaccines were very limited. And so because you had some level of immunity we would expect with a COVID-19 infection, you didn't need to be first in line for a vaccine on top of that. Now that vaccines are widely available, there's no data that says you cannot get another vaccine because you've just recently had a COVID-19 infection. Generally, many clinicians will say you want to wait till you're feeling a bit better. So if you're actively having a fever, your body is already actively fighting infection, you want to make sure that it has the capacity to have the right immune response to a vaccine. So usually I don't recommend it during an active infection, but once your symptoms have resolved, I do recommend my patients to get vaccinated. One of the reasons is we know that you do develop immunity from infection, but it's not consistent. There are some people who will develop a large amount of antibodies from a COVID-19 infection, and some may not. We know that from the vaccines, because they've been tested in the way that they're developed, we all will that have normal immune systems will have a similar response to that vaccine. So I still do recommend vaccinations, even if someone has gotten a COVID-19 infection, just because there's more consistency with the level of protection that will be received from vaccination.
Great to know. Any other questions? All right, well, if that's it, Dr. Knight, thank you again for updating the presentation again in the space of just a couple of weeks so that we all have the most up-to-date information. We really appreciate you.
Of course. Thank you for having me.
Thank you. All
Y'all
right,
take
have a
care
great
now.
day, everyone.
Bye-bye.
Thank you.